Good morning. Good morning. My name is Robert Giugliano, and I'm an investigator, senior investigator with the TIMI study group in Boston. And I'm here this morning to talk about adherence and an interactive monitoring system at the heart of the issue. And part of my role is as a cardiologist at the Brigham and Women's Hospital and Harvard Medical School in Boston, but also a large part of what I do is to work in clinical trial research. And one of the studies I'm involved in now is in an anticoagulant trial. Another study I'm involved in is in lipid lowering and secondary prevention. And in both of these indications, one of the challenges that the treating physician faces is adherence with medical therapy. And that's the topic of this morning's presentation. We're going to talk about how important an issue this is, and then a potential solution that is being developed by FB Communication. And I want to take this moment also to thank Fulvio Bruno and his team here at FB Communication for involving me in this exciting work. So this really summarizes the issue here, that it's important for physicians to have a clear understanding of whether patients are taking their medications as prescribed, or if they're not, then why not? And that's the crux of the issue. If there are barriers to taking medications as prescribed, then physicians can recommend a number of proven interventions to help improve the compliance. However, if you're not even aware whether a patient is compliant or you don't have an understanding for what those barriers are, why patients are non-compliant with therapy, then it becomes very difficult to improve adherence to therapy. So I want to start with just a couple of terms and clarify this. Actually, in the medical literature now, these terms are becoming more widely used. So what does compliance mean? Well, compliance is kind of an older term. Adherence is a little softer and is now becoming the preferred term. What this means is the extent to which a patient acts in accordance with the prescribed interval and dosing of a drug regimen. So that's, is the patient actually taking the medication as prescribed as they should? The other term you'll see used in this field and in this presentation is called persistence. And that's the duration of time from the initiation of therapy to discontinuation. And so you'll see both of these metrics and terms referred to in the research and work that's being done in this area. So the first important point and message in this field is that it's a huge problem. Non-adherence is a very large problem, beginning with just the percentage of patients who don't adhere to their therapy who have chronic conditions. It's been estimated that as many as half the patients are not adherent with their therapy. And as you might expect, there are differences according to patient age and what the condition is and whether it's a symptomatic condition or not. But this figure of about 50% is sort of the midpoint. Certainly in older people with chronic conditions, it may be even higher. This non-adherence with medical therapy then is clearly tied to bad sequelae. For example, in one study, it's been estimated that 10 to 25% of the deaths in the U.S. could be tied back to non-adherence with medical therapy. And consequently, even if the patient doesn't die, non-adherence to therapy, not taking your anticoagulant, not taking your antiplatelet agent, leads to hospitalizations and other medical complications that cost a lot of money. In fact, it's been estimated that $47 billion per year are related to medical non-adherence causing hospitalizations in the U.S. The cost annually to the entire healthcare system has been estimated at $100 billion. It's a very complicated web of relationships when you try to understand why patients are not adherent. So on the left-hand side of this slide, you can see the types of non-adherence. So it can start with, we have all the good intentions when we send a patient out of our office with a prescription that they will take the therapy that's recommended. But sometimes they don't even fill this prescription. And it's surprising how often this is. Maybe as much as 25% of patients won't even fill the prescription you give them. Then even if they have the prescription, do they take the dose? Are they forgetting to take the dose? Are they taking the right dose? This is critically important with some medications with narrow therapeutic indices, like an anticoagulant, like an anti-seizure drug. So it's important to take the right dose. Are they taking it at the right time? Are they taking in the right condition, with or without food, as is necessary? And do they persist in their therapy, or are they stopping it early? Stopping an antibiotic course early, stopping or interrupting therapy because of vacation. So there are a number of different types of adherence, and then when you try to think, well, what are the factors that cause this adherence? And you can see we've listed 5 here: patient-related factors, and these are factors that have been identified by the World Health Organization, who's become very interested as well. Medication-related, prescriber-related, pharmacy-related, and then those issues related to the healthcare system. It's a very complicated relationship. So the reason why a patient may not fill a prescription may be related to that patient. It may be a problem with the pharmacy if they don't stock that drug or that particular brand. It may be a problem with the healthcare system in the U.S. If it's not covered by insurance, then the patient's not likely to fill the prescription because it costs them too much. So you can see it's a very complicated web of interaction here. I'm going to talk about a particular disease state at the moment, and one that I've been involved in for the last 3 to 4 years, and that's atrial fibrillation. As you know, in atrial fibrillation, it's a common problem that's becoming even more common as the population ages. In the U.S., we estimate over 5 million people have atrial fibrillation, but in the next generation, this number is going to more than triple and may even approach 50 million. It's a disease state that's related with very high costs, because the medical complications of atrial fibrillation, including stroke, are some of the most devastating to the patient. So estimated over $6.5 billion per year. A critical issue with managing atrial fibrillation is that patients have to take their medication, their oral anticoagulants, in order to prevent stroke and embolism. And yet we find in studies that the most common anticoagulant, warfarin, is discontinued 10 to 26% of the time, and that in fact, even in the first year, it may be as much as a third of the patients are not taking warfarin after being diagnosed with atrial fibrillation. So it's a huge problem, and it extends even to the newer anticoagulants, and we have some very interesting and new, simpler, easier to use anticoagulants to replace warfarin, and one example here is dabigatran, but it's estimated that 15% at a year aren't even taking this newer, simpler, easier medicine. And if you're not taking the medicine for anticoagulation and atrial fibrillation, you're not protected. And in fact, in some ways, these newer medications are at higher risk for non-adherence. If a patient doesn't adhere with a new short-acting anticoagulant, misses a dose or two, they're immediately not protected. Whereas with warfarin, you had a half-life that ranged 3-4 days. If you skipped a dose, it wasn't as bad. But now with the newer anticoagulants, you don't even want patients to miss one dose. And some of this, of course, has back to do with our ability to keep track of what's going on to the patient. Are they monitoring? In the case of warfarin and vitamin K antagonists, it's important to monitor the blood tests. But you know that this is a burden on the patients. Many won't follow up. They'll miss their appointments. They'll stretch them out. And in studies, maybe half don't attend follow-up after starting an anticoagulant, and as many as up to 2/3 are not monitoring their pulse, so they don't even know whether they're in atrial fibrillation or not. Some of this is education. We list here the last bullet, poor patient beliefs, where doctors are too busy to educate the patients on the disease on the disease state and what the therapies are, but some of it that patients are more likely to take their medications if they're symptomatic. So if you have bad arthritis and you can't get out of bed because your knees hurt, or your hip hurts, you're more likely to take your medicine. If we're talking about disease states that are asymptomatic, so anticoagulating to prevent stroke and atrial fibrillation, cholesterol lowering, treatment of blood pressure, these kind of chronic diseases where the patients feel perfectly fine, it's very difficult for them to accept, to understand they have to take their medication even when they feel well. So what are some strategies and potential solutions? Well, there are behavioral strategies, there are strategies that rely on technology, and we'll show you some data from actual studies that have been performed and published that utilize different strategies to improve adherence. But one of the challenges is you're dealing with that complex web of interactions, and you have patients, you have caregivers who may be multiple. It might be on one day the physician, another day a nurse, another day a healthcare assistant, and you have a variety of people who pay for the medications and these services. So it really needs to be a fairly broad system to be successful. Nonetheless, whether you're using a behavioral strategy or some new technology, everybody has one goal in mind, right? And the goal here stated is an adherence program that will enhance trust and interaction between the physician and patient, with the motivation to increase the patient's ability to self-manage, because if they can manage it themselves, they're more likely to be adherent to the therapy. They can monitor their own health. A good working solution would allow one to tailor to an individual patient and needs, because an 85-year-old elderly woman who lives alone has different needs from a young working person who has a busy, hectic schedule and is taking care of family and worrying about work and travel. So the needs are different. The system needs to be flexible. It needs to be very simple, and it needs to be something that can be incorporated easily in part of the patient's everyday life and routine. So let's think about how technologies could possibly increase adherence to medical therapy. So we have a number of advances that could be utilized. Digital health media, we have modern technologies. Almost everybody has a smartphone, right, that we rely upon to wake us up in the morning, to find our way to where we're going, to pick out a restaurant. Well, why not to help us be adherent with our medical therapies? So by leveraging these technologies, we can have smarter interactions with our patients. We can work systems that have interventions that are not so obtrusive, but are very easy and comfortable for the patient and don't bother them incessantly. And it'd be nice to provide feedback to the patients to remind them, to take their medication or how they're doing, or monitor their health status throughout this. And it'd be nice to be flexible enough where some patients will need more support and some will need very little support. So if the system could be flexible according to the patient's desires and wishes, that would be a tremendous advantage. So what are some options with modern technology? Well, telecalling, of course. I think text messaging is one that we're seeing now, particularly with the younger generation, who I'm amazed with my own children. I have to instruct them to make a telephone call because they much rather interact by text messaging these days. That's really the preferred method. And if we're talking about treating generations in the future, I think we have to understand what is the technology that they use. There's obviously online communication. I think you find this increasingly used worldwide. People going to website for information. Patients come to my office with things they've downloaded from the web about their medication or their disease state, and they want to know. Sometimes it's good information, sometimes it's not good information. Well, we should be using these same technologies to improve the medication compliance and adherence. And there's certainly a number of other ideas. Modern electric pill dispensers, instead of those difficult to open one day at a time tabs. And what we'll talk about in a moment is an interactive monitoring service that's comprehensive, that utilizes many of these technologies, that's designed to encourage interaction and patient feedback. I want to take a moment to show you some examples from the medical literature of what's been tried and some successes, and so that we can build upon that. So this was a study that